ask a very basic question. Is DDH more likely in boys or girls? Who thinks boys? Boys. And who thinks girls? Everyone else. Okay. So we now know that DDH is almost exclusively in girls. You hardly ever see it in boys. Hardly ever see it in boys. And this is the biggest study in the literature of it's thousands, it's 64,000 live births, looking in an area called Blackburn, which is in the middle of England, at how many of them had DDH, picked up on ultrasound scanning. And they only ever found 4 boys with DDH. So their conclusion was DDH is almost exclusively a female disease. And that's becoming more and more obvious as time goes on, that if you see a boy with DDH, often there's something a bit more complicated. And girls tend to be the ones you see most often. But the main risk factors are family history and breech positioning. And in fact, if you look at a meta-analysis of all the risk factors, the breech and family history come up there, but females are very high up. So your risk ratio of getting DDH, if your breech presentation is 3.75, females 2.54, left hip 1.54, first child 1.4, and family history 1.39. So basically, if you're firstborn girl breech, you have DDH until proven otherwise. So when you examine this kid in the clinic, one side is limited in terms of abduction, one side isn't. Does that make you think that this person has DDH? Who thinks yes? And who thinks no? Good, because the answer is no. Because, yeah, no, I know you're saying the opposite to what you know. So actually, a limited hip abduction is a common normal variant, particularly if it's bilateral. So a lot of children have adduction contractures when they're born, just like they have flexion contractures when they're born. If they're unilateral, that's a bit more of a useful sign, but it's still not a brilliant sign, particularly when they're really young. So you have to wait till they're around 8 weeks of age, and then if it's still limited, then it's much more likely to have DDH underlying it. But if you examine them when they're newborn or at 4 weeks, 6 weeks, a lot of children had limited abduction, but not necessarily anything wrong inside the hip. And that's been shown over and over again. So limited hip clinical signs only become more useful as the child gets older. That's the message. So that's why an ultrasound scan, when they're 4 weeks, 6 weeks old, is much more important than you examining. There are lots of kids who've had DDH missed because someone's examined them and thought everything's great. And there are lots of kids who are dysplastic, so the hip is in, but the acetabulum is dysplastic. So the examination is completely normal, but the hip isn't growing well. And you can't see through it. You haven't got X-ray eyes, so you need ultrasound eyes. You need an ultrasound to look at it. Andreas Roposch, who works in London at Great Ormond Street, did the study and involved pretty much all of us in the UK and many people in Europe. And it's a Delphi criteria study. So a Delphi criteria study is where you get expert consensus together. You ask a bunch of experts, do you think this sign is useful to you? Do you think this sign is not useful to you? And you ask about every single one. Do you think females are more likely to get it than males? Do you think, would you use a Pavlik harness in this situation? And putting everyone together, because there's not much evidence. A lot of this is eminence and experts saying this is what I do. Most people think that an Ortolani-Barlow test, if that's positive, asymmetry in abduction of 20 degrees or greater, breech, leg length discrepancy, and a first degree relative, those are the important things to worry about when you think this patient has DDH. But ultimately, you need an ultrasound scan. So this kid comes in. So in that clinic, they come and we examine them. I don't know why we examine them. We found out that most of the things we're examining for don't mean anything anyway, but we examine them, get the child comfortable, and then we do an ultrasound scan. And you see an ultrasound scan with about 40% coverage. So my first question is, do people use the graph method here when they're doing ultrasound scan? I think the graph method is the standard method. I have to say we don't, but most of Europe does. But most of the UK doesn't use graph. There's another method called the dynamic Harker method, which was developed by Harker and Clark, Nick Clark, who's in Southampton. And that's looking at femoral head coverage. Rather than measuring all the angles, the graph angles, you just look at the amount of coverage. And there's another method called the dynamic modified Morin or Terjesen method, which is what we end up using. And what that is the amount of bony rim percentage. How much cover, how much of the head is sitting inside the acetabulum, how much of it's sitting out. So we have a one-stop baby hip clinic. There are 2 rooms. There's an ultrasonographer or a radiologist in each room. There's 4 of us there, 2 of us in one room, 2 of us in the other room. All our trainees and registrars and fellows are there. And the kids, it's like a production line. The kid comes in, examination on the table, static examination first, then dynamic to see if you can make the hip come out or not. And then if it's dysplastic or dislocatable, they go into a Pavlik harness. If it's a completely dislocated hip, we put the harness on and then rescan them in 2 weeks. And if it doesn't relocate the hip, we discard the harness and move on to a closed reduction. But I know that Manu, I know others will be speaking more about DDH, so I won't go into details about the harness, etc. What I will say is in the UK experience, and that sort of mirrors North American and continental Europe experience, is if you use ultrasound screening as your main method of treating a child with early DDH, it's a very effective method. In over 90 to 95% of cases, it solves the problem. The problem really is that this is not screening. So I'll say screening effective in DDH. No, this is not true screening. True screening is, for example, when you screen for cervical cancer, where you have a problem that you understand the natural history of, and you have a treatment that's cost-effective, acceptable, and will make. We know that if you give that person that treatment, it changes the natural history. What we don't know with DDH is really the entire natural history of it. We have some idea, and we haven't got a test that is 100% sensitive and 100% specific. It all depends on who's doing this screening. It gets better the more you do it, and the more specific the protocol you follow, but it's not 100% specific sensitive test. So there's a lot of expert and experience-based treatment of DDH. I always do this for this. I always put a harness on for this. It's not evidence-based. And if you look at a Cochrane review of screening for DDH, as in all the screening protocols, there is insufficient evidence to recommend it for daily use, other than what they do find evidence for is if you delay your ultrasound, so you don't do it too early, because a lot of people do an ultrasound when the baby's 2 weeks old or 4 weeks old, when the hip is very immature, and they end up over-treating a DDH. But if you do it delayed, so 6 to 8 weeks, and then you splint those that have got dysplasia, then it's a very effective treatment. What isn't cost-effective is screening the entire population, which some countries do, like Germany and Switzerland and Austria, where there's universal screening, but it's not cost-effective. So in this child that we've seen with limited hip abduction, who's 6 weeks old and has 40% coverage, who would leave it alone and say, off you go, we don't need to see you again, everything's fine? Who would say, I'm not sure, why don't we see you back in 2 weeks and do another ultrasound? And who would apply a Pavlik harness? Okay. So this is the last bit of talk. So if 40% coverage, actually the studies show over and over again, is not enough coverage at 6 weeks. So the thresholds are between 39 and 51. Anything above 51% femoral head coverage is great, and you don't have to do anything about it, you can discharge them. Anything below 39% is pretty much dislocated. But anything in between is not good and needs treatment, particularly if they're at least 6 weeks old. And that, if you follow that protocol, and so this is from Bristol, of treating those that are dysplastic in that range, then they tend to have very good results. So this is a group of 128 hips treated following that protocol of discharging them if they're over 50%, but then treating them if they're under. There was one grade 1 avascular necrosis radiologically, but other than that, everything else was fine. And the reasons they tend to not do well, so using a Pavlik harness, which we'll talk about in one of the next talks, but the reasons they tend not to do well tend to be that the harness isn't holding the hip in the right position. So if the hip is dislocated and it's not being reduced, or it's dysplastic but it's not being held in the correct position, you can see that often on an ultrasound. You can see that it's not lying below the labrum, it's lying at the edge, and it tends to get stuck to the capsule or starts to wear away the acetabular edge and gives you what's known as Pavlik harness disease, which is you make the acetabulum worse because it's not sitting in the right place. So some people have moved towards a modified protocol of the harness where you put it on initially with a harness, and if after 3 weeks it's not stabilizing, then you convert them into an abduction brace. And that, in all the studies that have been published about harness use, that's the one with the highest rate of success of about 93%. If you use a combination of a flexible harness and a more of a fixed brace, if the flexible harness isn't working. So we've done a systematic review about the whole harness, which is in the journal of JPOB, if you want to have a look at that. But for me, the summary is, if it's a girl, think DDH. I've had both my daughters screened, even though there are no risk factors, because I got paranoid. The main risk factors are breech, family history, females, left hip, and firstborn. But we, as surgeons, trust in those, but also think that limited abduction is useful and the Ortolani Barlow's is useful, which is fine, as long as you're not missing cases. There are lots of ways of screening, and you have to find the one that works for you in your practice. That's what works for us in our practice. And generally, if you're less than 50% coverage, you need to start some sort of treatment, and then monitor constantly for improvement. Thank you. Any questions?
I have one, Manoj, because it's a little bit controversial. I know that all the literature says that if you have less than 50% coverage, you should treat it at 6
weeks, yeah.
You know, one of my problems is that when you talk to the parents really get paranoid by starting a treatment with a pelvic harness, at least in my case.
Okay.
And I look at our experience with around 48 hips, that by 4 weeks time, they have an ultrasound with less than 50% of coverage. That with a clinic, a normal
exam, yeah.
Nothing going wrong with it. And by 8 weeks, they were getting normalized, and by 12 weeks, they were perfectly normal.
Yeah.
So nowadays, I tend to follow up on these patients a little bit closely, and I do not indicate a pelvic harness in the first place. But I know that in my experience, you know, we had 88% that went well,
yeah.
But still 12%
they didn't.
That we started a late treatment. And I'm afraid, you know, my question is, I don't have enough numbers for that.
Yeah.
To if I delay the treatment, what impact this will have by delaying for 4 weeks to 10 weeks or 12 years, or 12 weeks.
I don't, you know, and my other problem is that, are we measuring the same thing every single time? So, you know, if that same kid came an hour later and you did the scan, would it still say? And I don't know, because we haven't got a standardized method. The graph is as close as it gets, but even then it's not. I know you have to look at the 9 things to make sure you're absolutely in the graph plane. And I just, 2 months ago, I was in Stockholm and we ran a course with graph. So it's a graph ultrasound course. It lasts 2 days, and all you do is teach everyone how to do the graph method. And it's very, very exact. But even then, when you watch people who say they do graph, see what they're doing, they're not doing graph. And if you ask them to point out the 9 things, they're not doing graph. So I think that's a problem, because those 12 may not have been 40% or whatever you decided the cutoff was. So
how many pediatric orthopedic surgeons are actually doing the ultrasound themselves? I don't do it.
So I don't because we have our radiologists. Some people do. In fact, interesting, in the UK, the people who do it themselves are people who are in smaller hospitals, have their own sort of clinics where they have the machine next to them. The ones who are in tertiary centres don't do it. And the only reason we have this setup is because we wanted it more like a multidisciplinary setup, so it was one stop. But otherwise, most other tertiary centres see them in clinic and send them off for their ultrasound and then see them back with the result.
I have a question. You know, between the Ortolani's test and the ultrasound, now I get a feeling after your talk that, you know, less importance is given to Ortolani and more importance to ultrasound. Is that the case? Is that what we are trying to convey?
Yeah.
I mean, I think because on one hand we can't generally screen all the kids for cost-effective reasons.
Sure.
So don't you think that Ortolani test is a very important test, at least for the primary care providers, if we are not screening?
Do you mean Ortolani or do you mean Barlow's?
Well, I mean both actually,
okay.
Because Ortolani's sign in some, you know, they talk about Ortolani's test, they include both the...
So, and my other question related to that is, do you think when someone says this is an Ortolani positive, do they mean that it's truly, or is just a click? Because there are lots of patients who get referred to us as Ortolani positive, and actually it's just making a soft tissue click. It's not an Ortolani positive.
I'll tell you what I follow.
Yeah, please.
If I examine a hip and I don't find it to be an Ortolani positive hip, there's a click, If there's a click, I order an ultrasound. Otherwise, I don't order an ultrasound if it is autolinear negative. I mean, obviously, I mean, should not be a teratological hip and it's also autolinear negative. What I mean is that it's a anomaly. So that's
Yeah.
the dictum I follow. I don't know.
We change a little bit.
Yeah.
This was my other question.
Yeah.
The UK, because we have a problem in our country. We have a very high incidence of DDH.
Yeah.
And
you do.
most of our ultrasounds are done by radiologists. So sometimes you cannot really have a sense if it's done in a proper way.
Way or not,
You're
yeah.
gonna see a lot of changes. So we decided to run a registry for all the DDH. So we do a prospective case studies for all the children that were born in Portugal. And we try to come out and see what's happening actually. Because we're still seeing a lot of late presentations.
Yeah.
And so something should be missing for sure. We are doing something wrong in our country. And one of the questions I think we have is the evaluation by the radiologists. Giving mix-up information. So I think it's really important that if you do a hip clinic, that you are familiar with the ultrasound and you can judge yourself. Because it's not like an X-ray. An ultrasound is not like an X-ray. It's always the acetabular index is going to be the same.
Yeah.
And as you mentioned, if you do an ultrasound 2 hours later, you can have maybe a totally different image.
But I mean, this is why we set up the way we did. So we're there for every ultrasound.
So
To be
my other
honest.
question was, what are the indications? Because you don't do a universal screening with ultrasound.
Mm.
So what are your indications for an ultrasound?
So, till 4 years ago, our indications were family so risk factors being family history and breech, and then there's a baby check and a 6-week check that the midwives do when a baby's born. So abnormal findings on that, and that meant different things to different people. But we'd rather have them send to us if they found something abnormal than not. Then 4 years ago, the NHS released something called NIPE, which is the National Infant Physical Examination Program. And they stipulated exactly which babies should be screened. So this is for every newborn. So it's for hypothyroidism, phenylketonuria, every newborn condition. And their criteria are family history of breech, but the exact criteria were for whether it's breech pregnancy, and if there's any member in your family who ever had a hip problem. So not did anyone in your family ever have DDH, or not did they have it when they were young. Has anyone ever had a hip problem in your family? And that's a positive family history. So we get more now than we did before because everyone sends it because there was a positive family history. And then the clinical factors are limited abduction, leg length discrepancy, a positive Ortolani Barlow's, but not clicks, but people still send clicks. So there are national criteria now for what we should screen and what we shouldn't. We, on top of that, tend to screen kids with calcaneo valgus, because there are papers that show there's a relationship, but not kids with congenital talipes equinovarus, so not clubfoot. And we've published on that, other groups have published on that, saying that there's no link. We've done a study of 150 kids, prospectively, and x-rayed every single clubfoot kid and didn't find anything. So torticollis is sometimes, but it's not fixed. So things like infantile skeletal skew, so mild scoli, torticollis, metatarsus adductus, all these molding syndromes, packaging molding syndromes, we sometimes do, but there's no consensus for that. That's more a feeling of when you examine the hip. But that's what we tend to do. But there are national guidelines for us. Not that they're brilliant, but there are guidelines we have to follow. Yeah, but this is why there are still late presentations. So we've looked at all our cases in our catchment area, and in the 3 hospitals where every kid gets sent to us, to our one-stop clinic, we've not had any missed DDHs. We still have roughly 6 to 8 late presenting DDHs from our hospital, as in born in one of our hospitals. And we get several more because we're in a part of London which is pretty much the United Nations. So they come from everywhere. They literally fly into London to come for treatment. So they come from all over Africa, Asia, everywhere. But we still have a late presenting rate in our hospitals, even though we screen everyone with risk factors. So, and the only way you can get rid of that is by screening every single person, but that's not, for us, cost effective. It would cost, so we worked it out in England, it would cost roughly £4.5 million to set up a universal screening program from scratch. And no one's going to invest that money.
Most of our cases are late presenting.
Yeah, I know.
Any specific reason for
Most of the cases I operate on are all they're presenting, but they're not born in our hospitals. So I do maybe 1 or 2 a week of late presenting open. You know, there's a lot, but they come from everywhere. Sorry, you. So the theory behind the left it's to do with the common presentation in your cephalic when you come head first of where your hip is lying against the sacrum. So because your commonest presentation is left occiput anterior, that's why. But that's just I mean, no one's really proven it. That's just a theory. Because that hip is more an adduction. So again, if you look at all this, so I've got a whole, I'm sure there's more harness stuff coming, but if you look at all the evidence for it, the minimum period of treatment is between 4 and 6 weeks, but some people carry on up to 3 months. By the time you get to 5 months of age, the kid is too big for a harness anyway. So if you're starting treatment around 6 weeks, you might take it to maximum 4 months. And then some people wean, some people don't wean, some people just take it off one day, some people. So there's a lot of variation in practice. Okay, all right, thank you.
How do you?
Oh yeah, sorry.
I think it's this. And
Yes.
how do you put it on there? Okay. Let me go here. So let's move to a more older child. And before I start talking, just like Manoj, introduce myself a little bit. I've been working for several years at the Lisbon Children's Hospital. It's not 1,000 years, but it's around 120 years. And actually it was set up in Lisbon by one of our queens that came from Austria and realized that there was no care for children in Portugal. And she was really the person that gave this, the field to the government to build up this hospital and supported this. And it has been going on for, as I said, for 120 years. And I also work at the hospital, private hospital outside of Lisbon. That's what I'm currently working right now. And I was able to set up a clinic for pediatric orthopedics. And I do a lot of research also related to biomechanics at what we call Instituto Superior Técnico, and trying to develop and learn a little bit how to approach the different problems, especially with walking and how the kids can manage. So let's go a little bit to an older child. This is a 6-month-old girl. No signs of hip instability at birth, no family history. The right hip was found normal at the exam by the pediatrician, but there was a limited abduction on the left hip, and that's why this girl was referred to us. There was a negative orthotomy, and the X-ray, you can see it here with a right acetabular index of 30 degrees and on the left side of 42 degrees. And my question, the first question we'll be asking you now, is this a bilateral DDH? Could be a bilateral hip dysplasia, or you found this dysplasia on the right and a dislocation on the left. So everybody goes to this one, yes. I think, just to go a little bit on the X-ray discussion, just to be familiar with this, it's all these Ilgen-Reiner and the Perkins lines, the Ilgen-Reiner coming here on the horizontal through, excuse me, maybe I can use this. Huh? Yeah, but I could not see it. I don't know it's coming here, but I'll use this. So here the Ilgen-Reiner line going through the 3 radiate cartilage, and you have the Perkins line going to the lateral border of the acetabulum, and you expect to have the femoral head on the lower medial quadrant. And here you can see it's going a little bit further up and lateral, so there is no doubt that you are dealing with a dislocation on the left side. The other question is the acetabular index that can give you some ideas how you would approach, and you have how you measured. And as I said, it was 30 degrees. You expect to have at this age at below the 25 degrees, and you have it around 42 on the left side. And you also can see an indent, what we call the false acetabulum. So my other question about this is, are you familiar with the Tony's classification? How you classify? And the question, this is for the panel. Do you think that this has any importance in terms of how you approach the treatment for these patients? Or do you feel that it has an importance in terms of how this child is going to behave regarding your treatment?
So I personally think that you can take an X-ray of that kid several minutes, but one X-ray every minute of 60 minutes.
And you have different ones?
It will be in different places. Between a 1 and 2 or between, so it means it's a static image. That's why arthrogram is a more dynamic thing. It tells you much more. That's my thing.
Some papers correlate a higher donors with increased risk of avascular necrosis.
Mm-hmm. Yeah,
For the established dislocation.
I think I think you're absolutely right about this. I think in the old days, there was to have a correlation between the higher level of the femoral head with a higher risk, more difficult to treat these patients. But I totally agree with Manoj that the clinical aspects, what you observe, and I think also I totally agree with you, the arthrogram is the most useful tool that I have in terms of the prognosis. But before you do the arthrogram, you also have the clinical aspects. So I think it's very, yes? Oops, what happened here? I was. You came out? And how do you do this? Yeah, probably. So I also think, when you see that patient that is 6 months old and we have a dislocated left hip, as you mentioned, are you still using a pelvic harness in a 6-month baby? No.
Not even Indian baby.
Remember, it has a limited abduction, no ortolani, no Barlow. So would you go into traction, close reduction, and plaster? Close reduction and plaster? Close reduction and plaster. Open reduction? Yes. Okay. So because this is a controversial thing, and I'm really happy that we have different approaches on this. Because when you go into the literature, maybe you are more familiar with this, Walton? Huh? Yeah, exactly. I think that it brings out the importance of the clinical aspect. And I always start if below 6 months, and then sometimes I even try up to 8 months to treat the child with a pelvic harness. Maybe you say, I'm going too far. But I think it's much easier for the parents to treat this patient with a pelvic harness than to treat it with a plaster, a closed reduction and a plaster. That means general anesthesia. I think what you have to do is not to force the treatment. Because some people tend to say, okay, you can use a pelvic harness, and you continue to use a pelvic harness for 1 month, 2 months, expecting that something is going to fall out of the sky and it will resolve the problem. And if the pelvic harness does not work for 1, maximum 2 weeks, you should discharge it, because otherwise you're putting that hip in a lot of stress. And I always give my telephone number to the parents, because if the child is crying, is not happy, you should monitor this. And so you can use the pelvic harness in a later stage. And this paper coming from Walton, what it really put it out is the clinical aspect, because if all the hips diagnosed with dysplasia or subluxation, that means that the clinical exam was absolutely normal. They were managed successful in the harness. So it's a totally different disease if you have a dislocated hip. And this you should really differentiate, because then you have a really high risk of putting this hip under a lot of pressure, and actually can be causing AVN or a disease of the pelvic harness that will be very difficult to manage later on. So I agree with this. Yes, you can treat patients more than 4 months age with a pelvic harness, but you have to monitor them very carefully. So what do we see also from this paper coming from France, from Paulet, on the results of the pelvic harness treatment in children with dislocated hips between the age of 6 and 24 months. So we're really extending now a lot. Honestly, I would never dare to do this because of what we have been saying previously, and I'm sure here in the faculty, when I see the people saying yes, it will follow the same idea of myself. But what is true is that on this particular paper, they were able to manage if the graph was a 3 graph classification and not a 4. So you were able to manage in this in a proper way. The only thing that I would be a little bit scared about this is that the hips that failed the pelvic harness, there were 6, so it means that 50% ended up with endovascular necrosis. So I think we should play it in a safe way. So what about the pelvic harness? How do you do it? You know, Manoj already started to talk a little bit of this. So its indications, especially for 0 to 6 months, I can extend it to 6 months. You know, the important thing is that at rest they are dislocatable, so that means they could either have a Barlow sign or have a subluxation. And if they are out at rest, they are reducible. Because if you really are not able to have a reduction, you can try it with a pelvic, and I have seen some of these children reducing, but they will reduce in 2 or 3 days. And if they don't reduce after 2 or 3 days, it's better not to force the use of the pelvic harness. So you really have to explain to the parents what you're doing. So how does it work? You have the anterior straps that are made for flexion, and you should keep the flexion between 90 to 100 degrees, not more than that, because you have a risk of causing some impingement of the femoral nerve, and you can then have a paralysis of this. And you use the back straps to do the abduction. And most of the time, the abduction is to reduce the hip. And I never force the abduction straps. I always keep them loose because I know if the hips falls into place just by doing on flexion, they'll go naturally into abduction. So you don't really need to push it more than that. And we know that when you push it, the abduction straps too hard, you can end up with the problems. So what will be the contraindications to use the pelvic harness? Out at rest, so they are irreducible. As I said, you know, you have, for example, arthrogryposis, a very stiff hip. You should not try to use a pelvic harness. If you have a myelodysplasia with neuromuscular problems, you should stay away from using a pelvic harness. And also, if you have excessive laxity, because the hip can go left, right, up, and down, I think you need to have a more stable immobilization like a plaster to use on this. We're talking about this, how to use the flexions and the abduction straps. So what is the anticipated outcome? If you have an in at rest, that means that is a dislocated hip or Barlow positive sign, you can expect to have 100% of success. And if you have out at rest, that means that you have a positive ortholine sign, you can expect 85% of success. But again, I think you have to be very careful and to monitor these patients to avoid the complications. So what are the complications they can face on? Failure or reduction that come up to 5 to 20%. Osteonecrosis, they can up to 0.5 to 28%. And this is something, I don't know what you would be experiencing, because I would like to hear from you how to use the pelvic harness, how much AVN you can get from your experience, because this is one of the reasons that forced me to delay a little bit the starting of the treatment, because I realized that in our own experience, the early you start treating those patients, the more likely you have a chance of having an AVN. And we already talked about the femoral nerve palsy and the pelvic harness disease. So what is this for the faculty? What is your experience regarding AVN with the pelvic harness?
I don't have a very good follow-up, to be honest, of pelvic harness cases because You mean to say that prolonged use or any use?
Any use, and if you start, because what I felt in my experience is when you're using too early, you have a higher chance of ending up with an AVN. So I think that the hips need to mature a little bit to start the treatment, and that's why we stopped doing ultrasound very early, not to exaggerate in treating children that maybe they'll do by themselves well, and to avoid these kind of complications.
What age did you start?
The pelvic harness, the treatment, between around six weeks. Yeah.
So I think any earlier than that, we've had problems before.
Yeah, exactly.
So when we get them to come for their scan at 6 weeks, and not before that.
That's also what we're trying to do.
I think quite a good number of the autolani positive as well as the Valo positive hips stabilize over a period of time.
Yeah.
Personally, I don't start any treatment in 6 weeks away, because a high percentage of them stabilize.
I mean, that's what Bala showed, got 90%.
Yeah.
Bala.
Yes.
Yeah, that's-
I don't know whether it's autolani positive hips would stabilize. I mean, I would probably wait for just a couple of weeks and then put the arms for autolani positive, not Valo positive. I would wait.
Yeah. But even for the ortholani positives, I have been seeing, because I work close to the maternity, so sometimes we are called because there is a real ortholani, and we don't do anything to these kids. And you'll see that some of them, they would do well naturally, and you do by 6 weeks, and you have an ultrasound that's absolutely normal, actually. So I think we tend to be very conservative on the approach on this.
I have a point here, because once you have a autolani positive hip and you give the pelvic harness with the hip in, I would rather give the pelvic harness with the hip in than to find after 6 weeks that the hip is out and try to gradually reduce it, because I feel, and I don't know whether you agree, that the chances of AVN is much more than.
Mm-hmm.
So, I mean, 2 weeks is the max I would give, because I would know that I'm going to reduce it after that on tape.
So, and this is a good question. I really did not look at it. If you have an ortholani sign, that means that the femoral head is out at rest. Okay, we all agree that we don't treat it on day 1. You ask them to come at 2 weeks' time. I ask them to come at 3 weeks' time.
No, I would do an
More.
ultrasound every week.
Every week?
Yeah.
I schedule them to come and see me in 3 weeks' time when I see clinically if the ortholani is still there or not. If you still have a positive ortholani, yes, probably these are the exceptions that I start treating right away, because I agree with you. Why to wait for 6 weeks' time to start treating those patients? And I can agree with this. But my other question is, and that's where we came out, by 6 week time, 40%, but the clinical exam, absolutely normal. You treat them, I still wait for another 2 weeks, just to see how does it go. Little changes with not too much impact.
Maybe we need to do a study.
Yeah, maybe. Okay. So here I have a very good example, still being able to work out with a 6-month-old baby that was treated at this age with a pelvic harness, and you can see that 6 months later you have a perfect remodeling on the left hip and everything works in a perfect way. Again, the question is, whenever you use a pelvic harness, you have to monitor your babies in a perfect way and instruct the parents how comfortable are the children feeling. Because I always say that the problem with using a pelvic harness are the parents and not the children. If the children is not feeling happy, something is going wrong, you have to discharge using the pelvic harness. That's for sure. If the parents are not feeling good, you have to treat with the parents and talk to them. Another thing that I realize, and this is a practical way, it's not coming in the books, and I don't know how it is here, it's the wear, the clothes that the children are using. Because I see sometimes, these children, you try to put them a pelvic harness, and they come with a very tight jeans that they come in induction all the time. And I realize that's because of the clothes that the things is not working a proper way. So it's something that I instruct the parents what appropriate clothes, and usually I try to tell them that just to leave them free of clothes so that they would not impinge on the treatment. So, message here, Again, the only way to ensure normal health in an adult life is to detect the disorder at birth. But we realize that, to do that, you will need to have an ultrasound universal screening, and this is not cost effective. So we really have to have our sense very oriented. And the primary care patients, we try to develop a lot of courses to the primary care doctors to make sure that they have the right diagnosis and they send in the patients. And that's why when we started our registry in Portugal, we involved not only the orthopedic surgeons, but the general practitioners, the pediatricians, and the radiologists because of the ultrasound problem. So we try now to have one single way of approaching the problem. There is no doubt that the earlier the treatment, the better the results are. Dysplastic and dislocatable hips have better prognosis. You see that on the literature, kind of ended up with 100% prognosis, good prognosis. Dislocated hips out of the sockets have the worst one. Gentle reduction is the most important thing, no forceful treatments. So if the baby is crying, stop your treatment, check what's going on. Open reduction does not have higher rates of AVN compared to closed. And I think you're going to look at this in your presentation. I'm not going to say too much about this. What you need to make sure is you have a concentric reduction, because it's the only way to ensure that you're going to have a normal development of the acetabulum. And one thing that you have to always keep in your mind when you're talking and treating DDH patients is you should intervene only to alter an otherwise adverse natural history. So you have to know and be familiar with the natural history, because some of these treatments can be aggressive, and you have to make sure that you're making an impact on this treatment. Thank you very much. I don't know if you have any questions for this.
When are you going to design your own clothing line for babies? That's what you need to give them.
No, actually, you are kidding, but I always tell to the parents, the old skirts that they have, that's what I tell the parents, forget about using pants, just use skirts, even if it's a boy, put that a pink skirt, please, and leave the legs alone.
I have a question. It has been said that if you use ultrasound, there is a screening method in all patients. It has led to overdiagnosis and treatment in many patients who are not in need. So the consensus is that we do examination. First time, if somebody detects there is something is wrong, then we refer the patient to pediatric orthopedic surgeon. He will take care of the patient. And in one study, it was found that about 90% study was done by an orthopedic professor. That 90% even orthopedics don't know how to elicit Barlow's and Ottolani test. So, sir, this time maybe I am working in a periphery in a village. So if I detect that something is wrong, maybe when I refer patient to pediatric orthopedic surgeon, the child, he may be normal. So we have to take care that if somebody suspects something, then we should take care of that patient, and we can go for ultrasound in that patient. And as our ultrasound as a screening method in all children, sir, it has resulted in overdiagnosing the patients.
Let me see if I got your question in a perfect way, and maybe you can correct me if I did not understand properly. I think when you approach this problem, and as I said, I had a good experience in my country where we realized, because when I moved to the Children's Hospital 10 years ago, I realized we were getting a lot of referrals from old children. And when I talk about old children, it's like 2 years of age with a DDH, what I think is really old. And I realized that it was missing a lot of information. So as you mentioned, we really started to build up a national registry. It just started 1 year. It took us a long time to build this up, because if you're working on a national plan, you have to work with pediatricians, general practitioners, imagiologists, radiologists, to really help you building up a consensus that everybody is working on the same direction. And then you have to build up a structure that answers to those problems, because you're still in my country. One of the things that happen, you have a child diagnosed outside of Lisbon with a DDH and ask for a referral to the clinic, and sometimes can take like 3 months to come to the clinic. That's not acceptable. So if you build up a screening tool, national screening tool, you also have to build up an answer when you identify the problems.
No, but what he's stating is that when you do a screening of all the kids, you're actually overdiagnosing the problem. So he's saying that, he's not for screening, the universal screening. That is,
So I agree with you. I think, universal screening by ultrasound, it's too expensive. So and you still see in countries like Austria, Switzerland, and Germany, you still have late diagnosis. Because we have been seeing also that some patients that have an ultrasound that are normal, they can come up later on with a hip dysplasia. And maybe this is a different disease. I also have, it's just one case, it doesn't mean anything, but shows it can happen. That a child at 4 years of age has a perfectly normal x-ray of the hips, and by the age of 12 has bilateral hip dysplasia. So maybe there is something related to the development of the labrum, and we don't really know exactly what happened. You are talking about the boys. We know that the boys, they all do worse than girls. Why? Different disease, probably. So there is something. So I don't really believe in universal ultrasound screening, but I think that people have to be alert. And just by what we could see by establishing a national program, that is in the last 2 years, we don't see any more babies coming to our clinic that are more than 12 months. So we really went down to those, but we still have some late diagnosis, and I think we still need to improve. But this needs a lot of teaching. Every year we go to the Pediatric Congress and we talk about this and we discuss with the pediatricians. So you really need to have a lot of interligation. But I believe that the clinic, and that's why that paper from Rosposh, a lot of people put emphasis on the abduction. You say that there is no evidence that abduction, limited abduction, has anything to do with hip dysplasia. But it's something that we know that can be a sign, an alert sign, if people are familiar with it. It does not mean that everybody that has a limited abduction is going to have DDH. And we also know that some of the cases that we see with DDH has a completely normal clinical exam. And this is what sometimes is very difficult to understand.
A couple of things. The limited abduction is only in the very young child. So
Okay.
up to 8 weeks. So we were talking about a 6-week-old child.
Yeah.
So just a comment if I can make.
Sorry, can I just say the screening programs, the universal screening programs in Austria, Germany, Switzerland, they don't completely get rid of the late presenters, but it definitely reduces the incidence. It's not cost effective in most other countries. But what they've done is set up a screening program that's absolutely uniform. It's graph, it's done the same way, every single child in graph's little device that he puts babies into. And that's different to setting one up in the UK where everyone's doing different techniques, or in Portugal, and people who say they're doing graph versus what they're actually doing. So I think there probably is a role for it, but you have to set up a program that's absolutely consistent in the whole country, which has so many implications, and that's the problem. So I think we definitely set up even in England.
Yeah. There was a question? Yeah, please.
So I'm Dr. Ashwini from Agra. Just a comment. Ultrasound as a machine, as a screening tool in the chamber of an orthopedicians, even if he's not a pediatric orthopedician, does make a lot of sense in today's practice. Not only in pediatrics, even in other joints. So as a screening tool, there's nothing wrong to overdiagnose, as long as we don't miss the cases. That's all. Thank you.
No, I think it's a very good comment. And again, for sure, if you're doing do a lot of ultrasound, probably going to discover a lot of hip dysplasia in the very young, in the newborn, like in the first weeks. But the question is, and this is the important thing, is to decide when you should treat them or you should wait. Because not every child that has at 3 or 4 weeks has a hip dysplasia should be treated. And this is where your mind should be focused on. I think it's important that you identify those cases, because we still want to achieve a method that we treat all these patients with DDH at a very early stage, because that's your goal, is to avoid late presentations that we know that can give you bad results at an adult life. So in order to do so, I think we have to be very keen and very strong in terms of observing these children. And if you can have an ultrasound on your side, then maybe it's not so costly. Because actually, I tend to say that ultrasound is like the stethoscope of the orthopedic surgeon. So if it becomes a familiar tool that you use on a daily basis and not something that you have to order and to pay for that extra exam, maybe you're saving a little bit of your costs.
But then it's not a regular ultrasound. It's
So the only problem in this country is to have an ultrasound, you have to register with your PNDT Act, and that is a hell of a problem.
Okay.
See, in this country, India, for using ultrasound, you need to register under PNDT Act, Prenatal Diagnostics Act, and that creates some problem for orthopedicians. But I think IOA should work in this direction. If we can find some way out for orthopedicians to use ultrasound without getting into that network of PNDT, because it's a difficult job. Thank you.
Okay, if no other questions, we move into an older child. You have your seer?
Yeah, I have. You want me to take it out? Yeah, I'll just take it. Yeah, that's fine. We're just going to continue with DDH because it's such a complex, that's why it's called developmental dislocation of the hips nowadays, not CDH. Yeah. All right, now we are going to be talking about a 9-month-old boy who came for the first time to me. The birth history is unremarkable. There's no history of DDH in this. The parents noticed the problem since 3 months, doing well otherwise. The chief complaints were limited movements, left hip noticed while changing diapers, decreased active left hip movements. On examination, limitation of abduction of the left hip as compared to the right. The mother noticed it. Decreased active also, decreased active movements of the left hip relatively. Telescoping was positive over the left hip. There was a limb discrepancy of 2 centimeters, left less than right. Neurologically intact lower limbs otherwise with plantars flexors. Other bones and joints were normal. These were the X-rays that they were carrying. So now I think in the last talk it was clearly documented how to see for a dislocation with the Hilgen-Reiners and the Perkins lines. So I think nobody has a doubt that there is a dislocation on the left side, which is unreducible. This was not done by me, but it was stayed outside. So in this particular case, the next approach was, we thought that yes, we talked to the family that yes, we need to get this hip in because this is not going to go in, but we actually did an ultrasound. We told the family that we'll try a closed reduction and see under general anesthesia, if the hip can go in and we are satisfied with the closed reduction, then all is well. Otherwise, we are not going to hesitate to do an open reduction. So in this particular case, you can see the femoral head, you can see the triradiate cartilage. The femoral head, there's a lot of medial joint space, and you know that the hip is not reduced. And sometimes it may not be as evident as it is in this ultrasound. It can be very subtle. We'll probably talk about it in the following slides. And then we went ahead with an open reduction after a percutaneous adductor tenotomy because we felt that the adductor tenotomy will improve the safe zone. As to see, so the most important, the obstacles were the reduction. We did cut after we did an anterior approach, went through the anteromedial capsule, the ligamentum teres, the iliopsoas, and then also the transverse acetabular ligament. And this was the post-op X-ray. Now we didn't do any CT, but we do feel, I don't know what the panel feels, that after, of course, one has to be constantly there, supervise the spica application because that's the commonest time that you have a redislocation. But then if you have the epiphysis superimposing or rather overlapping the ischium, so then we are pretty much in and we are okay. So we don't do on a routine CT scan, but we did the X-ray and we were satisfied. And this was a post-op follow-up of 1 year, where the acetabular index as compared to the right side was still a little high. And this was after 22 months. Well, I mean, you can see that the hip is not really, but this was what we saw after 30 months. So clinically, the child was absolutely fine. There was a full range of motion, no limb limb discrepancy, normal activities. So just talking about our arthrogram, we do a subadductor approach, and a normal one is what you see on the right. Usually a good reduction is when the medial dipole is less than 5 millimeters. A fair reduction when the medial dipole is about 5 to 6, and anything more than 6 is unstable. And of course, we saw a frank dislocation in that case also. So a safe zone, just talking about the safe zone, especially after a closed reduction or even after an open reduction when you are planning a supplementary procedure, that a 30 to 65 degrees is fine. And then you have when you have a 35 to 60 degrees, then 40 to 55, and 50 to 90. So anything you may have 40 to 55 degrees and 50 to 90, then you know what to do. 30 to 65 degrees, you know what to do. Sometimes you may have to take on-the-spot decisions when it is 35 to 60, and then actually see the dynamic when you are doing a dynamic study. In age groups of 6 months to 2 years, we generally know that a closed reduction under general anesthesia we may try in the relatively younger children, and traction has no role because it doesn't really, previously lots of traction was given, but nowadays traction only in cases of very high dislocations. We want to reduce the amount of shortening that you want to do. Maybe you can do that in an older child, but otherwise it doesn't really affect the intra-articular, most of the obstacles are intra-articular. Consider adductor tenotomy to improve the safe zone. An unstable reduction, if there is a wide abduction needed, or more than 15 degrees of internal rotation needed to maintain the reduction. So you don't want that kind of a position for maintenance of the reduced hip. And arthrogram to see if the reduction is satisfactory. If not, don't hesitate to do a OR with a good capsulorrhaphy. Maintenance of hip, use of CT, well, we'll ask the panel at the end of the talk, and appropriate follow-up is important. X-rays are always gold standard. We even talk about the medial gap in the X-rays nowadays. Of course, we have already talked about the lines. Then there is something, what is supporting this kind of a management is that a study by Renshaw in which there was he talked about the inadequate reduction of congenital dislocation of the hips, at that time CDH. In his review of arthrography of the closed reduction, he found that interposed soft tissue remained in the joint which obstructed the reduction. So it just reiterates that these are the problems that we see nowadays. Hence it was clear that the soft tissue interposition with attempted CR was an indication for OR. And again, Lindstrom, Ponseti and Wenger, they had a paper on acetabular development after reduction in congenital dislocation of the hip. This study of acetabular development was conducted on 148 patients with 185 CDH treated by closed reduction, and significant and continuing improvement of the acetabular index was observed between 2 and 8 years after concentric reduction. So there are papers which talk about 8 years being the watershed. So whatever you need to do before 8 years, much before 8 years. And early treatment led to the best acetabular development. And Weintraub et al. Talked about the growth and development of congenitally dislocated hips reduced in early infancy, and they concluded that the hips recovering from congenital dislocation developed similarly as the normal hip, but differed in showing the greater rate of decrease of acetabular index and increase in CE angle. In other words, that there is a significant development after the age of 5 that was manifested in the reduced hip. So everything pointing towards the fact that early treatment was necessary for things to proceed towards normal. So the carry-on message is an arthrogram, an important dynamic study for the femoral head acetabular relationship is, and it has been established after an apparently successful CR. So after close reduction, you need to study the arthrogram to see whether it's okay or not.
and with the slightest suspicion of instability in inadequate CR warrants an open reduction. So you need to be talking to the family well in advance that, there might be a chance of an open reduction. Concentric reduction of femoral head into the acetabulum is the key for a good outcome, and do not relax till you ensure a well-mounted spica post-reduction. So that's the carry-on message I want to give in this particular age group. Any questions? What about, just wanted to talk to you about, do you do CTs after, no?
So, but I don't do capsular procedures, so the biggest move in the UK recently is worrying about what the cause of avascular necrosis are. And we've always relied on the capsulorrhaphy to be the thing that holds your hip in. But actually, getting the hip in the right place and taking the things out, that's stopping getting to the right place. That's more what holds the hip in. So, cutting the transverse ligament, taking out the ligaments, tears, etc., etc. Once you get that back in, to take the capsule that carries all the blood supply and to double breast it and squeeze it out. So we've been doing Doppler studies. What happens to, you can pretty much Doppler excision and watch the waveforms just drop off. And we try really not to do capsular at all. So we've done some animal work and we're going to publish some work soon.
Okay,
What happens is
interesting.
once you start surgical hip dislocation, you start thinking about everything that you do.
See, everybody who does an open reduction, I don't know, most of you would agree that it's not so easy to do fantastic capsulorrhaphy. Sometimes it's very difficult to get the bite on the medial anterior capsule. So what I do nowadays is to hold it with a forceps, Ellis forceps, then you reduce, then you have that capsule in front of you, so that you take a bite, a couple of bites from there, and then you hold. So you need not necessarily, double breast it, but if you have a good hold, that's good enough. I mean, that's how I do. Please. Yeah.